My name again is John Gordon. So I'm class of '06, which is, oh my gosh, almost 20 years now. And this building was something that they talked about and started hitting us up for money for back then. They were like, this wonderful building is coming. You're not going to get to use it. So hopefully you guys are all enjoying it as students. But anyway, our topic today is on healthcare. I think we're in a very, I hate to use the word interesting, because interesting is the word that you use when you don't have anything better to say. But we are at an interesting moment for healthcare in the United States. The data shows very significant disparities in outcomes across healthcare that's existed for a long time, not just between the United States and other countries where we get far less value for our healthcare spending than they do, but also when you look at within populations across the United States. The wealthiest 1% of the United States has the best health outcomes in the world, and other parts, less wealthy parts of our healthcare system have outcomes similar to third world countries, which is something that doesn't get talked about a whole lot. And put that against the backdrop of basically at this point, complete political dysfunction as our government is currently demonstrating, and very significant cuts to Medicaid that have come out of the recent bill that was passed by Congress. So it's a challenging moment. And I'll put that against the fact that healthcare has always been a challenging sector to invest in. And so we put a panel together here today to talk about it from 3 different perspectives, actually. And I'm gonna let our panelists introduce themselves. I'll go last and talk about my background as well. But as we listen to this, the 3 panelists here, we have someone from the investing side, we have someone who's been and is an entrepreneur, who's taken in capital, and we've got someone who's investing more from an organization nonprofit side, deploying capital to drive change. And I think some of the things for us to think about here are the time and scale of impact, the time frames themselves, how ROI is measured, because these are dollars that we're actually talking about deploying. And ultimately, how is the scope of healthcare itself big enough to actually address some of the problems that healthcare is responsible for right now? So with that, why don't we start at the far end? Manmeet, if you'd like to go first and give your background.
Sure. Well, it's a pleasure to be here. Like John, I am an alum, and so I do miss the older building. I thought it had some more charm. But lovely to be here. I graduated in 2012, and I came into business school with the actually background in global health and global economic development. So spent the first 5 years of my career pre-business school working in low-income countries. And then I'm from New York, came back home to New York, came to business school with an interest in starting an organization that took what I saw as sort of innovation in low-resource environments of using non-clinical workers in filling gaps in care in the US, in the health system in low-income countries. And I wanted to do something like that here in the US. I was very motivated by a desire to pair high-performing business operations with creating a job-creating business that delivered financial and clinical results. And I've just spent the last 15 years working on that. I started out with a 501c3 called City HealthWorks for 9 years in New York City and Albany. Experience taking in philanthropic research grants, subcontracts from health systems. And then during the pandemic, right before the pandemic, had converted the entity into a for-profit and taken an equity investment, and then made a big pivot to running a medical practice in Washington Heights, which we started through acquisition and debt financing. So experienced debt and equity financing in that period of time, and then later joined forces with a larger group to co-found a company called Diverge Health that acquired the coaching model that my team and I had built that showed a 7-to-1 ROI to help scale that into 4 states. And so the most recent entity was a Google Ventures-backed company called Diverge Health. And then I am currently right now so taking a pause from company building and really enjoying working with a research institute in Indianapolis, where I currently live, called Regenstrief, to help foster more collaborations between industry and biomedical informatics and health service researchers. So looking forward to the conversation.
I'm Julia Iyasere. First, I would like to say it's an honor to share the panel, and I'm really excited for the conversation today. I graduated from the business school in 2008. and really didn't think I was going to go to business school. So I'm a doctor. I wanted to be a doctor my whole life. That's what I do. That's what I'm passionate about. That's what informs all my decision making. About halfway through medical school, I decided maybe it would be beneficial to get a second degree so that I could inform my clinical practice with more practical understanding of both investment and the sort of business side of healthcare, which for people on the medical side of things can sometimes be a little bit of a dirty word. They don't want to talk about the money. And unfortunately, I think that is a huge part of what we do, and we have to talk about the money. So 2008, I decided to take a little bit of a risk and a gamble and to come to the business school to learn a bit more. And I don't know that I touched on my business school background for quite some time. So I was faculty, I still am faculty at Columbia in internal medicine, and was very clinical for about 15 years. So I did administrative work at NewYork-Presbyterian Hospital, which is where I currently work, but really focused my time on being a good physician, being a steward of medicine, and on collaborating with patients to achieve their best outcomes. Throughout that time, I was a medical educator. I taught a number of courses in the medical school, and then had the opportunity slowly but surely to transition into the administrative side of our hospital system. Through a number of different positions, which I will not belabor, I ultimately was asked to found the Dalio Center for Health Justice in 2020. The Dalio Center is a dream of mine. It is a passion project which has become something of its own innovation hub, mini nonprofit within the walls of New York-Presbyterian Hospital system. It was originated with a $50 million gift from Ray and Barbara Dalio and Dalio Philanthropies. We've subsequently raised another $13 million more. And our goal in 2020 is the same as it is in 2025. To be a leader in the identification and elimination of health inequity. We try to focus on the structural factors that impede people's ability to obtain their optimal health. And what that means is I work from bedside to community to identify health disparities and then fund projects to close those gaps. Those are educational projects, they are clinical projects, they are community-led projects, it's research, it's fellowships that we run. It's really, I think, spans the gamut to identify the gaps that we have in our healthcare system that have been persistent, pervasive, and really haven't moved in quite some time, and try to figure out innovative mechanisms to close them. I'm sure we'll talk a bunch about ROI today and how we think about investing and impact investing. I will also, for those of you in the audience that are interested in sort of the philanthropic side of it and how philanthropy influences the work that we do, I'm happy to talk about that as well.
That's great. Wow. Jason Torres, born and raised in New York City, got into healthcare via mom, who was a social worker in New York City in the 80s, dealt with vulnerable populations, a lot of substance use disorders, a lot of domestic violence cases. And so pretty early on, really saw the gaps and inequities of who received and who didn't. Saw some similarities, worked on Wall Street, I have an engineering undergrad, went to RPI, and I saw similar gaps on Wall Street. So I started my career at Solomon Brothers, way back when that existed. I was structuring there. They were looking for some quantitative talent. And then I traded on the prop desk at Deutsche Bank, where I covered healthcare and really learned how to underwrite. What's a good business? Is this a good company? How much to pay? Went back to B school. I didn't get the opportunity to go here. I went to Stanford, came out, got the entrepreneurial bug, and I decided I was either gonna be the entrepreneur, back the entrepreneur. So I did a hybrid. I started investing my saved up bonus money into companies, and that's how I got into the space. I'm an early investor in Athena Health. I'm an early investor in WellCare, independent living systems. These are sort of big leaders in the space. And yeah, that's what I've been doing ever since. Started my career in investing at Mansa Capital, and I've since spun out, have my own firm, got anchored up, and we invest at the intersection of healthcare, policy, finance, impact. That's what we do. So we look similar for these large gaps in healthcare Can we monetize it? Can we remedy that gap? In fact, the name of the firm, Sana, is the Latin root word meaning to heal. And in Spanish, it's a synonym for a cure or a remedy, and that's what we do in healthcare. We study the policy, we translate that to a business strategy, and then help execute.
Excellent. Well, thank you, all three of you, for joining us. On my side, came into Columbia, even though my application said something entirely different, is that my intent was to start a business, spent a lot of time with the Entrepreneurship Center, ended up actually launching a durable medical equipment business with one of my professors, and did 3 years of selling medical equipment to individuals, actually. So while I don't have any sort of medical background, I did in some ways act as a provider. That's why I have no hair. All that hair loss occurred during those 3 years. But came out of that experience and realized I wanted to stay in healthcare, and so ended up actually at New York-Presbyterian in their Office of Strategy, started 2 weeks before the ACA passed. And so Julia and I briefly worked together. I was in Manmeet, and I know each other from some time during my NYP days as well, plenty of overlap. Jason and I have gotten to know each other more recently. But had the opportunity to do many things over at New York-Presbyterian, built their accountable care organization, their genomic medicine program, their telehealth program, their health policy center, and then built and ran their corporate venture fund. Did that through 2019, left there, went to Commonwealth Care Alliance in Massachusetts, which, rest in peace, CCA, was recently sort of, we'll call it acquired, but it was really sort of taken over as they were facing significant financial difficulty. But they were a duals plan, 40,000 very vulnerable Massachusetts residents, and was their head of innovation and venture, left there, started my own venture fund with 2 partners, $83 million. Did that, but realized that it's really different to use capital to solve problems than it is to use capital purely for returns. And that wasn't going to be enough to get me out of bed for the next 20 years. And so I stepped away from that, founded F42, which is a nonprofit focused on driving transformation in healthcare through a person-centered lens. As you'll hear from some of our panelists here today, healthcare, if it doesn't take into account the context of an individual, is going to be unsuccessful. It's one of the big failures we see in our healthcare system. So you need to understand the entirety of the context in order to support them. And I'll tell a really quick story, and then we're going to turn it over to our panelists. I just came back from 2 weeks traveling the world, but the crux of my trip was 5 days spent at the Aravind Eye Hospital in India. And some of you may have done that case. It was a Harvard Business School case. I remember I did it at CBS. And so I actually spent 5 days with the leadership of Aravind. And one of the stories they told us was that Aravind was founded to specifically address blindness, mostly cataracts in India. And they started going to the villages, doing the assessment of individuals in the villages and asking them, saying, hey, you qualify for cataract surgery, we're going to give you free surgery. Come to the hospital, we'll give you free surgery. They got 15% of people actually took them up on that. When they started try to understand why only 15% of people were taking them up on it, they realized that because these people had no transportation, they had no food when they got there. They actually didn't have anyone to go with them. These were people who were functionally blind, and they needed someone to go with them. So when they started addressing these contextual issues, so they provide transportation, they provide food, there's someone to support them, their adoption rate went from 15% to 80%. Very clear example of how context really matters. It's not just what goes on inside the walls of the hospital. So anyway, on that note, let me turn it back to our panelists. Each of you have capital coming into your organization and capital going out of your organization. And as we think about the flows coming in and the flows coming out, if you could talk about where the money came from, and then what did it allow you to do? So why did you take capital in the first place? And obviously in some places, if you have a venture fund, you kind of need capital. But why did you take capital in the first place, and what has it allowed you to do that you couldn't do otherwise?
Sure, I'm happy to start. So I'll answer that across the 3 chapters of essentially the same business model that I've worked on, but across the 3 different iterations. The first stage of it, as I mentioned, was a 501c3. And I started it, I was a class of 2012, so the Affordable Care Act was being formed at that time, and I wanted to build a business that would show defensible impact on reducing total cost of care. So if a patient on average is costing $30,000, what could we show in terms of impact of the average cost of that patient sustainably through impact on care? So that was the animating question, and I decided to start it as a 501c3, and I had lots of classmates who would say, like, why not just start it as a C Corp? And honestly, like, I don't have a beautiful answer to that question. I think it was a combination of I'd come out of more of a social sector, so I think it felt more comfortable. But I think the biggest factor was I wanted to prove it if it worked, and then I wanted to, capitalize. So I had essentially approached raising philanthropic capital as in the way that you approach it when you're in a for-profit and you're raising a round. So I had a professor who was working at Robinhood, and she introduced me to Robinhood. I had a connection somehow. Everything for me honestly came out of Columbia Business School to start, because I had never worked in U.S. healthcare. I'm from New York, but I had spent some time working abroad, and I was starting really from nothing. I didn't know the difference between Medicaid and Medicare when I was starting. So I was both learning the industry and also learning who's who. And so very, very grateful to the school. I just really tapped on the door of every professor and every alumni I could get my hands on and who had anything to do with healthcare. And so I started it as a 501c3 because I wanted to have the time to partner with researchers to get good data in healthcare and in any sector, really. If you're, as a company, doing your own promotion of your outcomes without external validity, especially in healthcare, it's difficult to sell it beyond a certain point. So with a long-term view, wanting to build something for scale, I knew was important. So at the beginning, it was a combination of philanthropic capital. Essentially, had two anchor foundations, Robinhood and the Robert Johnson Foundation, who agreed. They don't typically fund startups, but I promised that I would not come to them past a few years. I said, I'm going to get the data, I'm going to prove it work, and this is about building us a business. And on that premise, we had about 4 or 5 years of philanthropy squeezed out of that, coupled with subcontracts with Mount Sinai, with local FQHCs, and then we had some research subcontract dollars. And so basically, that took us long enough to get good data, good results. The studies took years to come out, unfortunately, but that's part of the learning. When the pandemic hit, we took a very different type of capital. So the plan was pre-pandemic. In January, I literally raised $5 million from a family office into the newly created C Corp. And the reason for equity then was that we had a product, a service that worked. We had early good data. We had one RCT that had randomized control trial that showed strong results for asthma. We were waiting, but we had early indication on our diabetes, hypertension of really strong outcomes. So enough to kind of go sell and raise capital. But it was an arduous process to try to raise at that time, especially in 2019, because the big focus was on digital solutions, and we were a technology-enabled service of a workforce. And so capital at that point was important to have some kind of innovation-oriented capital. So we ended up getting it from a family office because we still needed to prove more. We weren't sort of done proving. We needed to prove that we could get customers now, that we could get recurring revenue, not just time-bound revenue. So the purpose of equity at that point was to kind of go from pilot phase in a couple of counties in New York City and upstate in Albany to larger scale. But then 2 months later, the pandemic hit. And there was no health system that was going to pay attention at that moment to chronic condition management when the world was experiencing what it was experiencing in March of 2020. And so made a hard pivot. And so then my taking in capital journey really was a very grounding shift, where we basically went into becoming a small business, frankly. Went into looking for independent practices. My team and I literally walked the streets of the Bronx, walked the streets of Washington Heights, of Harlem. I was pregnant at the time with my third child, and I was running around like Elizabeth, New Jersey, or Trenton, New Jersey, Fort Lee, New Jersey, a lot of Korean doctors. And what we found is that these practices that are independent, that are not owned by the systems, still exist. I now can tell you there's about 2,000 in New York City, but they are, a lot of them under the radar. You can't even find them on Doximity. So it was a very just feet on the ground period of searching and searching for a doctor who wanted to let go and retire and willing to give us their patients, their clinic, their operations to try to like build from, fill a single site. So I ended up acquiring a clinic on 189th and Broadway, was serving about 250 patients a day, 14 specialty lines. So I had no experience doing that, and I would say the purpose of that was a very important experience in taking an revenue generating asset. The clinic was doing about $14 million a year in revenue, recurring revenue, existed for 20 years. And coming out of Columbia Business School where I was very involved in conversations around social impact findings, I remember coming and sitting down with Sandra Novelli here and saying, I've got a bank loan for $5 million, put my name on that loan. I've got this equity investment, but I've got this revenue generating business, and we have this capability on coaching that we know we can move it from fee for service into value. And it was like a shockingly difficult moment where I was pretty well connected. It wasn't like 10 years earlier, but I knew a lot of people. And the capital availability actually for a revenue generating healthcare business that was looking to invest in innovation and move, not innovation, but really business transformation from fee for service to value was really difficult. And I found that in that journey, I learned a lot about how different philanthropic, and even within philanthropy, different philanthropies have very different questions they're looking to answer, metrics they care about, or where they're playing emphasis. So I had to learn a lot about how to do that. With grants, learned about how to work with researchers to fulfill funding tied to research, which is different. In getting a bank financing for $5 million, had to go through an extraordinary amount of diligence, worked with a legal firm to do diligence for 9 months before acquiring a clinic. There were a couple clinics we saw where there was too much, the pages of legal issues were too long for us to stomach. All these clinics have legal issues, but you had to really carefully pick which ones you could live with. Anyway, so I would say that a big lesson, I would say, across like taking in philanthropy, debt, early stage, family office, and then the third chapter of my business career, I was working with a larger group, and we had investment from Google Ventures, where we started out with $16 million day one, did a Series A, within a year and a half later, and a totally different financing story. But it was built around acquiring the care model my team and I had built on a story of saying that it was built on 10 years of evidence and experience. So I think I would say, like, you have to really think about what money you're bringing in. Talk to people for experience, because if I knew more what I knew now, I would have approached things differently. But at the same time, as much as it was painful to get a lot of no's, I learned so much. And I more recently appreciate like my experience and ability to just be very comfortable with being told I don't agree or just no, and figuring out what's my case and how do I refine that and how do I understand how that looks like differently for a debt financing entity versus an equity or early stage equity versus a later stage equity. They're all very different. So they're important to understand to make those decisions.
I'll go next. So the work I do is, I think, very different in terms of funding mechanisms and the outcomes that we generate. And so I'll talk a little bit explicitly about those differences. So I am in, I don't know, I'll probably get in trouble for not knowing this number. It's $13 billion is our organization's size, something like that. Sorry, Steve, I messed it up. He's our CEO. So anywhere from 11 to 14, it's somewhere in there in terms of billions. We put hundreds of millions of dollars into our community every year. And that's part of our community benefit. Those are our community programs. That's our Division of Community and Population Health. They do phenomenal work, and they have done that work for decades. That is separate from the work that I do. It's connected, but it is separate in terms of funding from the work that I do. And part of that was because in the wake of the second wave of COVID, our organization, from our board to our executive leadership team, said, despite all of the funding that we have been giving, despite all of the programs we have been running, we are still seeing enormous disparities in our communities. And so we were set up specifically to be a fast-moving innovation hub within the greater network of the hospital to say, how can we work with all of these different stakeholders, not tied to the same requirements for 6-month turnaround to demonstrate ROI. So the funding mechanism that we have was specifically designed to give us the freedom and flexibility to say we may not see an outcome for years, and that's okay. That did require a lot of conversation at the beginning, and I think that's where we start to talk about trust-based philanthropy. So I have to hugely credit our donors who, they are technically grants, so we do turn around outcomes to them. We have a lot of meetings throughout the year with all of our donors to talk about the work that we're doing, to show the measures and the outcomes of what we've funded. But it was because of those conversations about time horizon, the hours that we talked about, when could we see a true and meaningful impact, that we're able to do what we do today. So we were funded initially with $50 million. As I said, we got an additional 13 after that. That is all unrestricted funds. And when I say unrestricted, it's not just that it's for operations of the center as well as for programmatic investment. It is unrestricted in terms of what we fund. I have long and lengthy conversations with our donors to explain to them what our strategy is for the upcoming year. But what we fund has a very simple, the underpinning of all of it is that it must address health equity. That's it. And what that is, we have the freedom to decide. It must impact our patients. So our patients and health equity. Within that, we are free to decide, is that in cardiovascular disease? Is that in renal transplant? Is that in sickle cell disease? Is that in our community? Is that in our hospital? And I'll share with you our website at the end. We publish everything that we do. But that flexibility to really tailor what we're investing in to the needs that we've identified allow us to be much more successful. So a lot of grants, and I think Manmeet referenced this a little bit in the beginning. So philanthropy can be restricted. Grants can be very restricted to mean you have to do something in this specific disease entity with this specific population, and that might not be relevant to the work that you're doing. And a lot of people in this space get then very kind of you get constrained by the type of funding that you have. I will admit freely that the center we are very privileged with the type of funding that we have. But what has that allowed us to do? Well, we've given, and I was getting texted because they're filming right now at my office. We've been funding a significant amount of research over the past couple of years, understanding that there are developing gaps. We won't have to belabor that point here to understand what those gaps are in the research spectrum and in terms of funding for research. But we were able to do early stage investments into our faculty who didn't have enough to get an R. They would not have been able to get NIH funding based on what they had already demonstrated, but we were able to fund them. So the person who is on camera at my office right now, we funded him, I think, with $100,000, maybe $50,000 to $100,000. He was able to get $3.5 million from the NIH. We had another that we funded with $50,000, able to then subsequently get about $6 million from the NIH based on some of the initial data that we were able to generate through our research funding. So we think about ourselves as early seed investors who help people develop either the health outcomes, the research outcomes, or just in general, the administrative outcomes to then demonstrate sustainability and success. In all of our, and I say all of our contracts with all of our grant recipients, we have a huge section that's about sustainability. So what are your outcomes? How are those going to potentially lead to either revenue generation in the future and or a demonstration of success so that we can roll that into our hospital, who has, I said at the beginning, about $13.1 billion. We have to demonstrate that this is either saving money to the hospital or is generating revenue in some way, shape, or form. And so the flexibility that we have is driven by really phenomenal gifts that we received from our philanthropic donors who understood that the time horizon of this work was not in 6 months. It wasn't in a year, and in some cases, it's more than 2. Right now, I'm just got IRB approval, yay, for a study that's about 2 years long for social determinants of health screening and referral programming that we've developed and been advancing over the past few years. And that's to look just at what John was mentioning, the idea that if we really want to focus on health outcomes in the healthcare system, we have to address all of the other impacts to someone's health, so food, housing, transportation, et cetera. I will go back and say I started as a doctor at the bedside. That drives all of the decisions that we make. Our ultimate goal is to improve the health and well-being of our communities. To do that, we have to think about things outside the walls of the hospital. Also, to do that, we have to recognize that the time horizon is more than 6 months. Many of these things have taken generations to develop, and they're not going to be solved within a year or two. So I think those conversations early on were how we were able to obtain the funding that we have, and we use that as our kind of guiding star and our North Star. So all of our grants are 2 years minimum. They all have baked into them sustainability models, data evaluation, clear measures of success from the beginning. And we work with everyone we've funded to figure out where they're going to get their next funding from.
So we have a bit of a different model. We have to go to institutions, people, organizations to raise capital, and then we've got to allocate that in with this particular strategy of increasing access, improving outcomes, reducing costs. That's our mission. And so in order to do that, we've got to really align ourselves with the organization's asset allocation plan, what's fire of the day that they need to put out, and so that's taken some time. And so raising capital is an arduous task, and then in particularly this environment has not been easy. And when you have this turmoil in administrations shifting and what they want to focus on, decimating the NIH, I don't even know if we have a CDC, that sort of stuff, shut down right now. It's all of this disruption, trade, tariffs, all of the stuff that's going on, it creates pause. And folks, it makes it difficult to be able to allocate capital towards a strategy. You don't know if it's going to be around, and so it's been challenging. But if I were going to do this again and not lose all my hair, I had a full head of hair. I know you joked about that. Be careful what you wish for. If I were going to do this again, I would only look for aligned institutions, and I would look for larger types of providers, like some of these hospital systems, some of the more innovative payers, and then healthcare foundations. So I've had to ultimately kind of migrate my way there, spending my time educating folks on how, it's almost $5 trillion of spend in the US, and that's almost half of the entire global spend, and and we're not even 5%, maybe 4% of the population, just the magnitude of how large of a scale and inefficient this is. I just don't have time to educate folks to get them over that. They've got to be comfortable with this is policy driven, government regulated. It takes a long time to get in, to get contracts. It takes a long time to get out. And it's very sticky in nature. And so they've got to be comfortable with, reimbursement. They've got to be comfortable with a government, highly regulated industry. If they're not, so I've wasted a lot of time and, trying to educate folks to get them comfortable. And so if I were going to do it again, I wouldn't do that. I'd only look for aligned institutions. And then on the allocation side, increase access, improve outcomes, reduce costs. That's what they need to do. And typically that's around technology, solutions, there's some services. It's usually not things that are under the microscope. Not that that's bad, it's just not what we know. We know the policy, we know the economics, we know where the dollars are going, and then the outcomes. And we spent all of last year just developing that whole language around impact measurement and management. There's a whole vernacular there. The impact thesis or your theory of change, you've got to develop that. And so what are your inputs? What's your approach? What are the outcomes, short-term, long-term? And then what's your ultimate impact that you have? And is it sustainable, repeatable, scalable? So there's a whole, like I said, language there. But the capital raising has not been easy. And if I were to do this again, I'd find my tribe earlier and focus solely on them and just go hard in the paint there.
How much time do we have, by the way? 20 minutes. Okay, good. Just want to check. So to tell two more stories that come to mind. One is your point about $5 trillion in healthcare spending in this country. I was talking to someone, a guy named Dave Johnson, who writes about healthcare a lot of the time. And he's been doing some research on what's called revenue cycle, which is basically just moving money around healthcare. Based on his analysis, he believes that 20% of US healthcare spending, 20%, $1 trillion, is spent on revenue cycle. We spend 20% of the dollars in healthcare just moving the money around. And does that make any difference in anyone's life other than the people who are actually making all the money off of it? Probably not. One thing to think about. So the question I want to get to next as we talk, and Jason, Julia, you talked about it a little bit, but I want to dig in a little bit deeper, and as we talked about earlier. This question of time frame and this question of impact. How do you think about the traditional venture fund cycle, and whether that's an impact fund or whether that's just a straight up venture fund? Is, they aim to get out. It's set up as it's usually called 10 plus 2, 10 years plus 2 optional extension years. So that's 12 at the outside. But ideally, you want to get out of things within 5 to 7 years because you want to raise the next fund and keep showing how that keeps going. Healthcare doesn't work that way. I'll tell another story from Arvind. They put up a slide and that showed their time frame. And they were founded in 1976, 49 years ago. And we're looking at this, and someone who I was there with looks at it and goes, "Look, it's the hockey stick curve." I said, "Absolutely, but it's a 49-year hockey stick. And if you look at it, there's a whole lot of stick and only a little bit of blade at the end." And to their credit, they only took a little bit of debt and have taken no other financing since then. The other remarkable thing I'll point out, and I think my fellow panelists will be even more surprised about this, even though 1/3 of the care they deliver is free, they run a 31% EBITDA margin.
No.
Yeah. This is absolutely amazing. It's an amazing institution. Now, they are a focus factory with very low labor costs. And I think one other thing to put out there for healthcare is that healthcare is beset by something called Baumol's cost disease. And it's not just healthcare in particular, but Baumol's cost disease basically says that if you have a very human capital dependent industry, your costs will move directly in line with the cost of your labor. And so you have basically very little chance to drive productivity improvement. And healthcare is at that moment, although with the advent of AI and robotics, I think I'm not going to say the next 5 to 10 years, but I'll say the next 25 years will be vastly different. And even a place like Aravind, where labor costs are really low, will be cheaper to do all that eye surgery with robots. Interesting question to come. But again, talking about 25-year timeframes, how do all of you, in your experiences, how do you think about both internally, but also messaging to your financial partners about time frame and impact?
I think a general theme or reflection for me on that question now is more coordination of money at the outset in ways that are more common on the for-profit side, less on the nonprofit side. But coupling coordination of funding rounds with much tighter, shorter metrics and milestones of saying, let me make it more concrete. I think right now with the VC model, we're coming out of 10 years of so much capital, and I think it creates a lot of a deficit of capital efficiency and discipline on making careful investments, building, showing that you've got both operating excellence alongside patient impact, alongside these pieces all coming together, your technology development. I think we are coming out of a gluttonous period of way too much money, hyper growth. And part of what's been lost is even around, when I look at colleagues and talent, there isn't the muscle of tighter cycles of showing impact on financial and clinical return, and then scaling with greater discipline. And we've seen now down round after down round, you've seen hyped businesses just wind down, with no exit. And so I think there's both the there's like this like idea that, you know, VC is too short cycle. I actually think it's been too long in its time horizon and too gluttonous in its check sizes, with the belief that if you invest quicker or faster, you're going to have more return on innovation. And I do agree with the importance of larger check sizes. I really agree with the importance that you can't just like grit your way in the way I did in my early 30s to like get somewhere. Like that's not very efficient or effective. But something in between, I think, is really important, like a bit more cost discipline, a little more like time horizon discipline paired with like the steadiness of knowing you've got unrestricted, you've got the right capital over X number of years versus just being that hamster cycle year on year.
I think my viewpoint's a little bit different. And I think that is probably driven because I'm very much embedded within the healthcare system. So when we're thinking about time horizon, we're thinking about mortality. We're thinking about chronic disease management. I'm thinking about how am I reducing the black-white disparity in maternal health outcomes is Black women die 9 times more than in New York. And those are the outcomes that I'm thinking about moving. To do that, my time horizon cannot be 6, 12, maybe even 18 months. But that doesn't mean that we're not extremely disciplined on how we get there. It's not a free-for-all. So we spent months establishing our executive committee for the Dalio Center, all of our checks and balances that it's extensive before we fund certain things. What's our committee structure for every single thing that we decide to fund? How do we decide on evaluation metrics? How do we actually assist our teams in gathering that data? What is the model of change? Everything must have a theory behind it. Is that something that's been established or studied before? Do we have leading indicators to tell us in 6 months, if you've hit this milestone, you are likely to get here in 12, in 18? So I think there's the larger time horizon with like, where is the American healthcare system going? Why do we have these persistent disparities year on, year out? Though that's what I'm thinking about. But in order to be extremely disciplined in how to get there, you have to establish process metrics. You have to establish midterm evaluation metrics, outcomes at 6 months, at 8 months, at 9 months. And if you're missing those, then it's a quick reevaluation of why. And so I think there's the intermediate steps that are measures of success, that if you're in a different environment than me, you can use that to generate additional funds of capital. But I'm really thinking of time horizon in terms of like, are we making a difference in people's lives? Are we actually adding to people's lives? Is their wellness better? Is the well-being improved? Are we moving the needle in any chronic disease management? Those things take a bit more time. And I think when we started the Dalio Center, we started with a lot of history. So I have a committee of the board of our trustees that I present to, that oversees the management of the Dalio Center. And we spent a lot of our first board meetings just doing history, talking about how we got to where we are, what are some of the challenges that we see within the American healthcare system, within New York, what do we see within the communities that we serve, which for NewYork-Presbyterian is all of New York City at this point, but what are some of the prevailing disparities that we want to tackle? And so we had a lot of conversations early on to say, this is the history, this is why it's not gonna be 6 months and I tell you I solved everything. If I could do that, amazing. I should win some kind of Nobel Prize because it's not gonna happen. But I think it was early conversations with our funders to explain why what we were trying to do was not going to be a short thing. It was then midterm process measures to show that we were moving in the right direction. And the last thing I'll say, because we haven't really talked about this yet, is that at the heart of every single thing that we do, at the heart of healthcare is our patient, is our community. They have to be involved in the conversation. They have to be involved in the derivation, the development of all of these projects, programs, and interventions. And one of the things that erodes trust more than anything else in a community is when you go in for something in 6 months and it didn't work and you pull out. You go in for another 6 months with a new idea, it didn't work, and so you leave. And so I think that also in terms of this time horizon, we're thinking about investment strategies, we have to think about the downstream impact of that. Every time that happens, it makes it even harder to restart because now people don't trust that you're gonna stay. So the other thing that we spent a lot of time doing was just talking to people and saying, we're in this for the long run. This is my job. I will be here year on, year out, and there's nothing we're asking from you other than some time. We want to join this with you. So I think that there's some downstream impacts to the time horizon that you have to think about. It's not just the funding. That's absolutely important, but it's what's your goal? What are you trying to achieve? And what's the detriment of doing things that are on 6-month cycles that have an ROI that you really can't hit?
We need to jump to Q&A in a second, but Jason, I want to give you a moment to answer that, just a brief moment.
10 years plus 2, we shortened that. We were allocating very consistently over 4 years, and then you have a 4 or 5 year harvest which means you invest for the first 4 years, and then you start harvesting, hopefully selling. So if there have been any losses, you've experienced them, and then you really start to see the uptick in the companies. And so that's how we try to shorten it, by just allocating consistently over those early investment period.
All right, any questions from the audience? Yes. Just feel free to just be loud.
Dived right in. I wanted to ask the universe of the vulnerable populations, and since when this notion has become more in the center, the spotlight for attention.
If I understood that correctly, when did the focus on vulnerable populations become more of a thing?
And the universe, the definition of how many people are we talking about here in the United States?
Yeah. Julia, you want to take that one?
Yeah, I think it's a great question. I actually think that's one of yours. We could talk about terminology all day long. We tend to use slightly different terminology in our center when we're thinking about the work that we're doing. But you have to define the community that you're trying to either collaborate with to solve a problem, to innovate with, to create a new solution. That definition has to be something that's shared. And so I tend to shy away from just sort of these overarching terms because they're not specific. For me, we are very specific about what we're doing, who we're working with, who are the communities that we're trying to impact. So I think the terminology like vulnerable population, I don't really know what that means ultimately. We really focus on communities that are experiencing health disparities. We focus on communities that have either been even underserved is something that we try to also think about that terminology as well, but underserved, underinsured, uninsured. So I think defining who you're trying to work with from the beginning is important. But I think that's different for all of us, and that's different for every healthcare institution.
We look at it, think about a very flat distribution curve, and that bottom quarter, 25%, in terms of access, least access, worst outcomes, highest cost population, that's who we'll focus on. And that can be based, and we'll stratify that based on if it's demographics, Black maternal health, terrible outcomes, LGBTQ populations, wildly uninsured or underinsured, the elder populations, letting them age in place with dignity and not in a facility, heavy on the cost section, even military, with mental health. So we look for the biggest disparities. Can we monetize and make a repeatable, scalable solution? And so the goal is to get that flat curve to be a very tight curve so you don't have these disparities and these gaps. 2 things happen. One, it's now concentrated, so you shouldn't have these massive disparities, not in the US, if we have things like standards. And the second thing is that the curve will then shift to the right, which means that you get better outcomes, more health equity. And so that's what we do. That's how we sort of look at it: a flat curve to a concentrated curve, and then the mean shifts to the right.
I'll throw out something just to be a bit of an iconoclast here. I think also in thinking about this notion of who might be vulnerable, let's just use that word, who might be vulnerable. I think that can be very dependent from situation to situation as well. I mean, you could be, a comfortably middle-class white family, and you're just one disease or accident away from all of a sudden being bankrupt, and not being able to navigate the care that you need. And so it speaks to the poor performance of our healthcare system as a whole. The poor performance is very much concentrated in those populations that you talk about, but is not limited to that fact either, as well. And so, you know, the work I think we're all trying to do here is to address all of that. Yes. I think we have, sorry, we got someone with a mic right there, and then we'll try and squeeze you in as well.
Hi. So I actually come out of Columbia School of Social Work, 95, many years ago. And I was a therapist, and I ended up managing in the COO role, the Chief Program Officer role, large nonprofits in New York City and the greater New York City area, working on social determinants of health primarily. And it was my passion. I even have personal background. I was a runaway when I was a child. I have chronic health conditions. I really wanted to focus my life on solving these big issues for the peers that I grew up with. And as I was doing the work, I was always disenchanted, right? So I was very fortunate and privileged that I had the ability to code. I learned how to code when I was 11, right? I went to Bronx High School of Science when I was very young. So I ended up not on that path initially, but I did go back into the financial industry and built websites during the .com era to help pay for Columbia. And so when I went back into social work and I kept moving through the ranks, every level I said, okay, I need to get a little bit higher so I can make impact, because I can't make it from here. I can't make it from here. I can't make it from here. And even as a government subcontractor partnering with federal grant money and state grant money, there was always barriers. And ultimately, the conclusion I came to was, of all the way the money was being funneled, was everything was being put in place to help people get wraparound services, right? And that makes total sense. However, the largest social determinant of health is wealth. Mm-hmm. And what I saw there was a dearth of was investment in helping people in the community, in their families, right? So you can have somebody with a chronic condition who can't work, but they could be living, cohabitating with people who can. And if you focus on those members of their family to help them build intergenerational wealth and get a career and become sustainable, then that will support the ecosystem much better than having social programs come in and impose that onto the family and then rip it out every time there's a change in government. So my question specifically is, what is your focus on helping people establish this intergenerational wealth within the family structure to help with the social determinants of health and long-term health outcomes?
We have time for one response to that.
I'm happy to take a step. If you want to do it, you're welcome to.
I mean, I just don't think there's enough of that question being asked or emphasis on that question. So I'm glad that you raised it. And for my work, it's been focused around creating a workforce that is delivering a financial and clinical results, so I sort of started my work with an intent or mission more centered actually around the workforce, and creating a health coach workforce that could become a sustainable role, because it's sort of what I saw growing up in my family. You know, there was no service that was going to fix underlying situations, and so I appreciate you bringing up the question, and I'm happy to talk more about it. But I know that we're short on time, but I think that's it's a underspoken about topic, I would say, in this theme. So
I'm just going to jump in with 30 seconds. First of all, thank you for the question. Thank you for going into social work. We need more social workers. They are the lifeblood of our organization, honestly and truly. The 1115 waiver in New York State, which we hope gets refunded, did have a large carve out for workforce development, because they understand that financial security is one of the leading indicators for overall health in our country. That our institution, so New-York-Presbyterian, does a lot of work in workforce development and career development and reaching back into our communities to develop pathway programs so that people can get into the health sciences. And whether or not that is as radiology technicians or as future physicians, all of these are potential opportunities for people to develop financial security, which is the leading, health is wealth. Wealth is health. So I would say that there are mechanisms both from New York State in terms of Medicaid carve-out. The 1115 was a Medicaid waiver that had funding in it, not only for community-based organizations, but for workforce development specifically. And then I would say every healthcare institution in the city, even if they are technically our competitors on paper, I will highlight that they do wonderful things as well. Each of them have career development pipeline programs that are focused on developing health sciences professionals in the future.
Join me in thanking our panelists. I know we got to go, but thank you very much for coming.